So it's only a problem if you're using the L-dopa. Toxicity and side effects, blah, 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 blah. That first statement under number 4. Don't worry about it. By the way, one thing you should do is titrate the dose up to the least effective, the dose, the lowest dose that's effective. This is what they do with this stuff. They titrate the dose up. Okay, a number of cardiac arrhythmias have been described in patients receiving L-dopa, including tachycardia, ventricular extrasystoles, and rarely atrial fibrillation. Okay? Even with pre-existing cardiac disease, the risk does not outweigh the benefit. The incidence of these are fairly low, so we're not really going to talk about it. Okay? It can cause rarely some of these things. I don't need you to really know that. That's not so important. Okay? The incidence of such arrhythmias is low even in the presence of sustained cardiac disease. Okay. Postural hypotension is common and often asymptomatic and tends to diminish with continued treatment. While L-dopa can produce this effect, it is more prevalent with the more potent direct-acting dopamine agonists, especially bromocriptine. Okay? L-dopa is converted to dopamine, okay, and you can get hypotension. However, the reasoning given right after it needs to be crossed out, where it says, "and is believed to arise from the actions of dopamine agonists on the brainstem, vasomotor center to decrease sympathetic outflow to the periphery." No, no, no. That's not the mechanism. The reason we know that is, if you give domperidone and a dopamine agonist, guess what? You still get the hypotension. What does that mean? Okay. Oh, wait. Take that back. If you give domperidone, okay, with one of these dopamine agonists, okay, you eliminate the hypotension. What does that tell you? Okay. Does that tell you what? Domperidone doesn't cross the blood-brain barrier, so what does that mean? Domperidone must be having its influence in the periphery. What we think is going on is dopamine via D2 receptors inhibits the release of norepinephrine in the periphery. So what you do is you have heteroreceptors, dopamine D2 receptors, heteroreceptors on norepinephrine neurons. When you activate those D2 receptors, you inhibit the release of norepinephrine. If you inhibit the release of norepinephrine, what's going to happen to the blood vessels? They're going to dilate, and that's why you get the hypotension. Okay? It's not, L-dopa is converted to dopamine, but if you use a carbidopa, it's not such a bad problem. But we're going to be talking later on about direct-acting D2 agonists. They really cause the problem. There's a big problem with them in hypertension. Okay? The direct-acting D2 agonists are going to cause hypertension to a much greater degree than L-dopa does. And it says dopamine and other D1 receptor agonists can dilate renal blood vessels, perhaps contributing to the reduction in blood pressure. I don't know if you remember that the sympathetic nervous system, you do have D1 receptors on renal blood vessels. Remember that from last year? But you forgot. Okay? And they cause dilation. D1 agonists cause dilation. Okay. The GI side effects include anorexia, nausea, vomiting, and epigastric distress. I just explained to you why this happens. If you get conversion of L-dopa in the periphery, the L-dopa goes and activates the CTZ, okay, and then you get nausea and vomiting. However, if you use carbidopa, you decrease the incidence from 80% to 20%. What? I think that means epigastric to me means pressure, like some type of pressure. No. Epigastric to me means like pressure. Epigastric. latchkins would be epigastric distress. Okay, behavioral effects. We're going to learn when we get to schizophrenia that too much D2 activity causes the symptoms of schizophrenia, what we call the positive symptoms. Those positive symptoms include florid hallucinations, delusions, paranoia, and also dopamine also runs the pleasure centers of the brain, which we'll learn later when we get to anti-schizophrenic drugs. So you can get euphoria, but sometimes the euphoria, eventually that effect wears off and you get depression. So depression, anxiety, agitation, insomnia, somnolence, confusion, hallucinations, nightmares, paranoia. All these can occur. They usually don't occur initially, but it's with long-term use of the L-DOPA. You will start to get symptoms that resemble schizophrenia. Big thing to worry about is hallucinations, okay, and the paranoia that you get. You'll find that out. When we activate D2 receptors, we get the positive symptoms of schizophrenia. Okay? So these things can overactivate those D1 receptors, D2 receptors, and then you can get the symptoms. Behavioral side effects are more common in patients receiving L-DOPA with a peripheral decarboxylase inhibitor, such as carbidopa, rather than L-DOPA. Why would you think that's true? Getting more L-DOPA, you're getting more L-DOPA to the brain, you're getting more dopamine in the brain, more to activate those D2 receptors. Okay. Atypical antipsychotics such as clozapine, risperidone, olanzapine, and quetiapine. Olanzapine is spelled wrong, by the way. Olanzapine. And quetiapine may be helpful in counteracting the behavioral complications of L-DOPA. These things, the atypicals are very mild D2 blockers, but they still control schizophrenia. We'll learn about them later on. So with these agents, you're not blocking the D2 receptors that powerfully, so you can use them to treat the psychotic-like symptoms without, to any great degree, okay, causing inhibition of blockade of D2 receptors in the striatum. We'll talk about that a little later. You want to understand that will be schizophrenia, and schizophrenia will be on this next test too. Dyskinesias. Okay? And akinesia means a patient loses the ability to initiate voluntary movements. A dyskinesia. Voluntary type movements begin to occur even when they are not wanted. Okay? When might you get unwanted? When might you get, okay, unwanted dyskinesias? Think about it. What would that be? What would that probably arise from? Too much dopamine. Okay? So sometimes they have what they call peak dose akinesias, which is the dose gets a little too high, you start to get these dyskinesias. And these dyskinesias, okay, unfortunately, and we don't understand what's going on. But L-DOPA gives you about 5 good years. There are peak dose dyskinesias, but all of a sudden, you start to see these motor fluctuations where you have dyskinesias and akinesias mixed in within an hour. You can have dyskinesia followed by akinesia, or vice versa. Okay, dyskinesias occur in approximately 80% of PD patients treated for 5 years with L-DOPA. The form and nature of L-DOPA dyskinesias vary widely in different patients, but tend to remain constant in character in individual patients. You don't know all of these. We're going to talk about the next topic is dyskinesias in this class. What's a chorea? Where do you think that word comes from? What word do you know where you can find the word chorea? Choreography. What's choreography? Dancing-like movements. If it is a dance, it's the worst dance on the face of the planet. Okay, sort of like. Okay. Then we'll describe what a ballistris is. Apoptosis is warm. I don't know if anybody can do it. It's like a writhing, warm-like movements. of the digits, or even maybe the extremities. Okay, that's what apoptosis is. Myoclonus is clenching. Okay, I know you know what a tic is. You can even get tremors. May occur individually or in any combination in the face, trunk, or limb. Chorioathetosis, okay, dancing in with these worm-like movements of the face and distal extremities is the most common presentation. Now, what do you think? Would be more common or less common if you add the carbidopa? More common. Why? More dopamine. Okay. The development of dyskinesias with L-dopa is dose-related. Dyskinesias can be alleviated by lowering the dose of L-dopa. However, this is at the expense of the anti-Parkinson effect. Okay. Now we talk about the really big problem. Okay. There is something called the on-off phenomenon. The on-off phenomenon. And whatever's going on, it's not simply related to the dose. In the on-off phenomenon, I wrote this down, I wanted to state it correctly. Off periods of marked akinesia alternate over the course of a few hours with on periods of improved mobility, but often with marked dyskinesias. In other words, you are sometimes off where you can't move. You have akinesia. A few hours later, you may have too much movement with dyskinesia. And it's not simply related to the dose. We really don't understand what's going on. But there's a theory. Okay? Here's what the theory is. We say, okay, even as we're treating, okay, the disease marches on. Even as we're treating, the disease marches on. Well, what they say is, as you lose more and more of these dopamine neurons, they take up the L-dopa, okay, convert it to dopamine, but they're not able to store it as well. So what happens is, you release most of it, and what it does is, it comes in like a pulse of, depending on the dose, you get pulses of dopamine, okay, occurring in the brain. These pulses, they believe, somehow mess up normal physiology up there, and then you get this on-off phenomenon. Okay? It's just a theory. So how would you think you would go about treating this? If it's coming in pulses, and that's causing changes, okay, in the normal physiology, and we don't really understand exactly what's causing it. How do you think you would deal with that? What would you want to do? You want to use something like continued release, so you have almost constant levels all the time. Okay? It's just a theory. If they have sustained release formulations, the best thing would be to have them on IV drip, giving continual amounts of it. But it's a theory that if we give it in a sustained thing, we won't get these pulses, we won't get these motor fluctuations. But to tell you the truth, they are hell to deal with. That's when you start having good control. You get these motor fluctuations. Now, on average, about 10% of all patients develop the on-off phenomena, okay, per treatment year. So how many years does it take for almost everybody to have the on-off phenomena? 10 years. Almost everybody will have the on-off phenomena. That's why we say the average person gets good control for about 5 years. Okay? And then you start to see the motor fluctuations. Now, they give all type of reasons. Okay? Peripheral pharmacokinetic, delayed gastric emptying, okay, may be a problem. Okay? Amino acid compensation with L-dopa for absorption. This is very important that you understand. Okay? Remember I said, what was the transporter called? A large, neutral amino acid transporter. Well, there are several neutral amino acids, okay, which are all substrates, or what's the word substrates? substrates for that transporter. If you're taking L-DOPA, you should limit your protein